right. Good afternoon, everyone. It is great to see so many people in person. And for those of you in my class, I see you. Thank you for coming. And in all of the other classes. I don't know why I'm going to stand, but I will when I speak. My name is Megan Putko. I'm an OBGYN and a global health researcher with appointments here at DGHI and in the Department of OBGYN. And I'm really pleased to have everyone here for this Think Global. We wanted to do this in the spring, but it's even more timely to do this now because things are becoming more and more relevant as the climate, both the legal climate and the political landscape around abortion are changing so rapidly with, as we see how this is played out across the legal landscape, how this is discussed in the political forum. Today, we wanted to give you a chance to also understand how it's impacting providers and patients here in North Carolina. So we've designed the Think Global to focus on the legal perspective first, and then we'll switch to Dr. Gray, who's going to talk about the provider perspective, and then Hogan and Montesby are going to talk about the patient perspective. So what are they bringing forward? I will introduce our speakers. Bertrand Smoger is online. He's joining us, I believe, from New York today. He works at the law firm Smoger and Associates, and is the current board chair for Physicians for Human Rights, and has really long been committed to human rights while specializing in environmental litigation. He, as an appellate attorney, has often worked at the intersection of law and medicine, including filing U.S. Supreme Court briefs for the New England Journal of Medicine, for the American Medical Association, and for U.S. senators. Currently, he serves on advisory boards for the Human Rights Center at the UC Berkeley and the Civil Justice Research Initiative, and he also serves on the board of Public Citizen, Public Justice, and the Conversation. So he is going to talk to us about his involvement with some key litigation around abortion rights. From Duke, we have Dr. Bev Gray, who is joining us again. She spoke to us last year, but I think will attest to the big change in North Carolina in the last 18 months. She is also an OBGYN and serves as the division director for women's community and population health with a research and clinical interest in complex family planning, obstetric care, and transgender health. Importantly, she has really led advocacy efforts at the department level, creating and running the DREAM team, and really working as an individual and statewide advocate for abortion rights and access. Dr. Wesley Hogan is a research professor at the Franklin Humanities Institute and History. She writes and teaches the history of youth social movements, human rights, and documentary and oral histories. She has written many books and currently is working with Dr. Gray and Dr. Jonah Schwartz to lead a vast connections project called Reproductive Care Post-Roe, which is in its second year. And that team produces the Abortion Care Today audio archive. And Montesby Reddy is coming from the Vast Connections to give us a student perspective. She's an undergraduate senior studying public policy and is pre-med. And she really is interested in the intersection of rural healthcare access and reproductive healthcare, and is drawn to this because of her upbringing in a small Texas town where it's really seeing a lot of the impact of this. So we are going to start with Bertrand, giving a perspective on his work in this field.
I'm going to be a little broader, but if you look at it, there's two mechanisms to challenge abortion that have occurred. The first one is post-Dobbs. There are actually a number of laws that were passed before Dobbs that came into effect at the time of Dobbs. So you're splitting them, but in all 14 states have banned abortion, and 3 others have banned it after 6 weeks. Now, challenging the second aspect is mifepristone. That is not over. What happened in the U.S. Supreme Court in the mifepristone case, even though it was successful from my perspective, 9-0, was only to say that there wasn't jurisdiction, that the people that brought the suit didn't have a present injury that allowed them to bring it. 3 states actually intervened in that: Idaho, Missouri, and Kansas. They're still pending. And the Supreme Court hasn't said whether they have the right to bring the suit. They'll win in that court in Texas. Anybody that's does everything that I think is horrible always wins in that court. They file it on purpose there. Then they go up to the Fifth Circuit. They always win in the Fifth Circuit. And then we have to rely on the Supreme Court. And that's another story. So that is the movement to stop abortion. The challenge to that is in state cases, and I wrote a brief in the Zorowski case in Texas, we lost. The problem of legal challenges in the state cases are that they're passed by Republican legislatures in states that are entirely red, who appointed the judges that are in the legislature. So it's you've got this the blue states where you don't have the restrictions, and they're going and trying to open up and passing that you can't in any circumstances do restrictions on abortion. The red states make it very hard. So what's the other choices of having effective legal action? One of the things is a brief I wrote in the U.S. Supreme Court and a case that was brought. The case of Moore versus Idaho was not brought by activists or people challenging. It was brought by the DOJ. And the DOJ brings the suit on the basis of saying that Medicare requires hospitals to follow EMTALA. EMTALA requires stabilizing care, and you can't have the you can't have the result of your patient be worse off by being in the emergency room. The Idaho law says the only thing you can concern yourself with is whether the mother's going to live. And it doesn't matter about health effects if the mother's going to survive. Idaho trumps EMTALA. So you have this conflict, and the conflict goes up to the U.S. Supreme Court. And I wrote a brief for Physicians for Human Rights. It happened that the DOJ didn't have any real examples of the problems that were caused by the difference of the law, because it just happened the way they had nothing. So we actually talked to them, and my brief gave them the underlying facts, which is why Ketanji Brown Jackson cited my brief both for Physicians for Human Rights, during the argument. If you read the decision, she cites where we talk about the dangers. They didn't make a decision there. So the reality of what they've done is it was unanimous, but it's again unanimous sending it back, basically saying it came to them prematurely. It actually did, because the state of Idaho changed the law in between the district court, the first court that had it, and the circuit court that reviewed it. The law the Supreme Court was reviewing was not current Idaho law. Originally, ectopic pregnancy was not an excuse. You still couldn't have an abortion with an ectopic or molar pregnancy. They caught on and say that was, at least even for Idaho, that was ridiculous. So they changed the law. That's what so the Supreme Court said, go back and now look at the current law. So what's the third way? So the DOJ is there. Then the third option is referendum. There are referenda currently in 10 different states: Arizona, Colorado, Florida, Maryland, Missouri, Montana, Nebraska, Nevada, New York, and South Dakota. The one we pay the most attention to is Florida. Everybody, and I'm working hard there. The only difficulty in Florida is the one that requires 60%. It's not a 50%. Most are 50% majority. Florida has a higher threshold, which might have been why the Supreme Court of Florida allowed it, because nothing has really gotten higher than 57%. So it's a harder task for them to get. So what is PHR, Physicians for Human Rights? This is encroaching a little in terms of what we've done, but we've done studies of physicians, not of the patients, but what practical problems do physicians have, and that's been the basis of all our legal briefing. So we have done studies that are available on our website in Oklahoma, Iowa, Idaho, and just this week we published our Florida study. So those are the basis of various briefs I've written in state courts, in Supreme Courts, or in the U.S. Supreme Court. So what do we highlight? Impact on doctors. There's two major areas. One is the dual loyalty. The doctors have a loyalty to their patients that is by, if we cite all of the requirements that doctors have to file in terms of the health of the patient. At the same time, criminally, the state says your patient never is number one. Our laws are number one. And our laws are going to, and this is the two recent ones, Idaho has 2 to 5 years in prison and loss of license. Texas is 5 to 99 years of prison and $100,000 per violation and loss of license. That tension is so high, and then the second thing is the abortion double bind, which is we write about. If you follow the law, and the law is not for the health of your patient, does the doctor at the same time have a large risk of medical malpractice suits because they have not done what's necessary for their patient's health? So I'm trying to go fast into what I had, but so if you look at the results, and I'll give some human rights aspects of it. One is there's substantial delay. Often doctors talk about waiting until their patient develops sepsis. They said, one person we interviewed says, do we get to the point where life is irrefutably at risk? How sick does a mom have to be for us to intervene? And somebody else says it feels like we're rolling the dice on people's lives, waiting because you have to have such a substantial level, or or whether the mother can die, and you're making that aspect of it. We've had people that said that people had performed C-sections to mask the abortion and show another, which is a major procedure that affects a woman for the rest of her life, and that's actually happened. When stopped, so then the aspect of in the Human Rights Committee, in General Comment 31, the health of the mother should be preeminent. There's a violation of human rights. The second aspect, is what happens when you tell somebody that they have to hold on to a non-viable pregnancy. A woman with a crania was told to go to term. That was completely non-viable. A woman with PPROM that was not going, with a baby that was not going to be survived, was literally told to go onto a plane and fly to another state. And while you fly there, if to make sure your placenta stays inside you, because you'll be carrying a 19-week-old fetus outside of your body when you land on the plane, if that happens while you're flying to the other place to deliver the abortion. We said, the Convention Against Torture is suffering, and I argued in the brief that this was actually a violation and it was torture to have somebody carry a non-viable baby that they want, and this is going to last a long time, and they have to maintain it. There's multiple examples of that happening under these statutes, with doctors afraid because it doesn't allow that unless there's a spontaneous abortion. And then what's not talked about is that there are, and this is the general, what if you're treating cancer, heart patients that are pregnant? You have to watch out, and you cannot affect, again here, the baby, the fetus. And is it a violation? So one person said, how many people do we have to go, how many medicines do we have to deal with for their heart? A person in Idaho had to be finally flown to Washington. She had severe pulmonary hypertension, and the doctor said she was not going to live. Now that legally is, and this is one of the arguments, is actually there's a discrimination because you're treating in health situations for you're demonstrably treating patients differently that are pregnant and not pregnant, because you can't follow the guidance that you would follow for a regular everyday patient. Pregnant patients are being treated for non-pregnancy directly related conditions, and that was something else argued. So I think it's the time. So the only other thing is, like I said, it's not an accident that infant mortality, which was going down everywhere in 2022, went up in Texas, Missouri, Georgia, and Iowa, all states with severe abortion restrictions. So I thank you, and I think I kind of kept to my 12 minutes.
Thank you, Gerson. That's I think those were some really powerful examples, and I will just speak briefly to my experience of having trained in OBGYN in two very permissive states that not only allowed abortion into the late second trimester, but funded it. And I saw patients that went through all of these things, and all of these decisions were heartbreaking and heart-wrenching for the medical team and the patient without the legal restrictions on them. So to imagine a person in their family going through this with restrictions that are like threatening and frankly torture on top of that is where we are now. So with that, I will turn it over to you.
So we'll get our slides up. So I'm Bev Gray. I'm an OBGYN here at Duke. I'm a native of North Carolina and lived here most of my life. And I think Gerson talked a lot about kind of what providers are experiencing from a legal standpoint. And I've learned a lot of legalese, but lawyers definitely speak different languages than doctors do, and they definitely speak different languages than patients do. And I think trying to bridge that gap is important. That's part of what we're trying to do with this project. So the post-Roe oral history project has been very important for us and for our team as we have understood the urgency of this moment and keeping the histories of people that are providing in restrictive states so that we don't lose this history. And we can keep these voices and share these voices so that people can understand what's really going on. Is this operating
yeah.
slides? Okay, all right. Okay. As far as disclosures, I have some research funding from industry, but otherwise, the most important disclosure from our team is that we all know and love people who have had abortion, and likely many of you in the audience do too. Abortion is incredibly common. 1 in 4 people with a uterus will have an abortion by the time they're menopausal, and it's very common. If people talk about it, like in a group of people, you know, people will open up and share their stories. Do something. So we're going to talk some about the current state of affairs in North Carolina. We'll talk about the oral history project, and we're going to connect those stories to some of the advocacy that we're doing here in the state. So go back in your time machine and think about where you were at on June 24th, 2022, when the Dobbs decision came down. And we all had in our minds that, you know, something was coming. We had seen the leak, we had heard about the leak. We were already kind of in preparation mode for what might happen. I typically take vacation during the Supreme Court decision weeks, which I didn't realize was a thing until until this whole, you know, job situation. But now, you know, mid-June is always a time. There's always something going on. So I was on the beach with my kids. They were boogie boarding and building sandcastles. And I get a frantic call from the head of Duke Health Communications. And within a couple of hours, I was on the phone with NPR talking about what was at stake. What was at stake for North Carolina? What was at stake for our country? And in action mode. So you know, everyone's had their emotions about it. And it's a roller coaster. At that moment, it was action. What are we going to do next? And for that first year after Dobbs, North Carolina became a destination state for care. So in 2023, 170,000 people traveled for abortion care in this country. That number is incredible, right? Think about having to travel for any other procedure that you didn't have money for, your insurance that you cover, and you maybe had to drive 10 hours for care. So North Carolina was right in the middle of that. So all of these states were quickly enacting bans, and we became a place where patients could come and receive care. And then after SB 20, North Carolina's abortion ban, we'll talk a little bit about kind of what happened to those numbers in a minute. We still became a site where people could get care, but there were new hurdles in place. And now we were sending patients to other states. This is just kind of a brief history of what legislation in North Carolina has looked like. And actually before Roe, North Carolina was one of the few states in the country where abortion was legal in cases of maternal health, fetal birth defects, and rape and incest, which was a little bit of an anomaly at the time. And then Roe became law, and North Carolina enacted an abortion law that limited care through 20 weeks. It was a little bit arbitrary, and that was actually on the books until 2017, when a group of physicians, including myself, brought a lawsuit against the state, and that 20-week ban was repealed. In the meantime, between 1973 and now, there have been multiple layers of laws and trap laws that target providers. And those laws added a 24-hour waiting period that could happen over the phone. And that became a 72-hour waiting period with ultrasound requirements and imaging requirements. And then with the SB 20, the 20-week ban was repealed before SB 20, but then SB 20 made things much more difficult for patients to seek care. They have to come in person for 72-hour counseling. They have to initial along every single line. They have to be told that even if the father of the baby is paying for your abortion, he's still liable for child support if you decide to go through them. And some other very insensitive things. You can go on the North Carolina DHHS website and look at the counseling forms that we have to read to patients. It's 4 pages. It takes a lot of extra time, and it acts on this assumption that physicians are not counseling their patients fully, which we are. We absolutely are, and it just adds this level of language that's unnecessary and really frustrating for us. So these are the North Carolina numbers. So there's a study called the We Count study that tracks abortion numbers by month by state. And they started tracking numbers in the 3 months before the Dobbs decision. And so you can see right after Dobbs, North Carolina had this increase in numbers. So we went from a baseline of like 3,000 to 3,500 cases per month to almost 4,500 cases per month before SB 20 was enacted. And so most states that have a ban will see about a 30% drop in their number of cases right after a ban goes into effect. And then people figure out ways to navigate care, to get through the logistics. And you can see now the number of cases per month are actually above baseline. This is data through March. Nationally, abortion numbers have gone up. And much of that is not necessarily the travel. Travel's part of it. But not everyone's able to travel. The national increase is because in states with access, they've done more things to increase access. So they've made it easier to get care. So Dobbs did not make the total number of abortions go down in the US. In fact, access states are doing great things for the people of their state. We're trying to navigate some patients. Telehealth is a contributor as well. But that's what's happening over time, kind of with the numbers. But I think we always have to think about the patients living in banned states. And this graph, I swear, every time I look at it, it just like makes my stomach sink to the floor, because this is what's happening in all of those states where care has been cut off. And many of those patients who would have had care are not able to travel. And so when Gerson was talking about those increases in maternal mortality and infant mortality, those are the people that are affected. And Texas in this graph had the highest numbers, but that was after the law in Texas had made a very strict ban. So that number had already gone down drastically. So were already patients that were traveling to other states. And so this quote, people can only grasp freedom at the level that they are free. It's really important for me in thinking about the work that we do as a group, because we need the stories of people that are in more restrictive states than we are. Because we've experienced both caring for the travelers and sending our patients out of state. So we're kind of a sort of a sandwich state in that way. But the voices from these states.
That rise in Wisconsin, is that Wisconsin?
Yeah, so they had a ban that was over.
Right. In a referendum.
But history is storytelling, and I've been in Wesley for a long time, and when all this was happening, I reached out and I said, you know what, we really need to tell these stories, because we had physician groups that were in communication with one another, talking about what we were seeing, and we didn't want to lose this history that was happening right before our eyes. And so why is oral history important? Why are doctors working with historians? Many physicians are kind of used to qualitative research and taking, interviews and stories. But I think oral history for our purposes has been, I told Leslie, I've totally drunk the oral history Kool-Aid. I think it's really important for this time and this work. And this QR code, we'll show it again at the end of the presentation, goes to our oral archive with some of the interview clips that have been pulled. So you can get a sense of what patients are experiencing or from the perspective of physicians. So we have an incredible physician network that we work with, and we've been interviewing people from restrictive states and hearing their stories and hearing what they're going through. And our students put this infographic together last year, just talking about kind of the overlap between oral history and qualitative interviewing. But I think for us, what's important is capturing these marginalized perspectives. And the interviews are really led by the interviewee, whereas qualitative interviews are very prescriptive and you're trying to, it's much more researchy. This is much more like you'll hear it in some of the clips. You capture the emotion, you capture the experience of the individual in a way that qualitative interviews do not. Okay.
Hi, everybody. First of all, I want to thank Dr. Hutchko for inviting us. It was really, we're excited to be here and grateful. And I wanted to also acknowledge how important, I did not want to do this project at all. I have a history of working in voting rights and youth activism for 30 years. And, but Bev has treated me and my family. She is an incredible physician and human being. And so when she called me a few days after the decision in 22 and said, can you do this? I had just started a new project. I was in Berlin. I had like a big grant to do. And the story that she told me had me like weeping on a sidewalk in Berlin. So so I came back early from that and I'm so grateful that I did. But I have never had to work with data like this. So I'm going to ask the abortion care providers in the room, including Bev, to sort of hold their ears for a second. One of the most important things about oral history is we have a duty to also do no harm. And so when we collect data, we want to make sure we treat it respectfully and censure those people who are offering us their stories. So when I looked at how to treat this data and keep it safe, I just looked at what had happened to abortion care providers since '73. So I'm going to share this with you, and I think it's really important for you to understand why the data and security protocols that we have are so crucial. So we've had, since Roe, 42 bombings of abortion care clinics, 196 arsons, 491 assaults. And probably most important for the physicians in the room, it's unlike any other physician group, there are 11 providers who have been murdered since 1973. Also, since the Dobbs decision, I think it's really important to note that stalking has gone up from 28 stalking in 2021 to 92 stalking cases in 2022. Burglaries have gone from 13 in 2021 of clinics to 43 in 2022. So arson, invasion, all of these bioterrorism threats have all gone up especially in access states. So this is a very comprehensive movement. A lot of my friends in New York and California look at me, oh, I'm really sorry you live in North Carolina. No, this is happening everywhere and access is really challenged everywhere. So it's something for all of us to be aware of and concerned about. So what to do as somebody who wants to be a responsible researcher and work with young people, the only way we could do the scale of a project would not be for me to interview 400 abortion care providers. So we invited students onto our team in the spring of 2023. We had 16 seniors. They were incredible and they got us started to see if we could make this happen. You can see from the slide, we have in the first 18 months done about 45 interviews with 34 providers. We have really a wonderful audio archive, which we'll share with you in a minute. But probably the most important thing to know is the Duke IT team has been unbelievably supportive in helping us figure out how to store the data, how to communicate with providers. We're totally off the Duke network because the Duke network is subpoenaable by Todd Rokita, the Attorney General in in Indiana, or Ken Paxton, the Attorney General in Texas. We want to make sure that our providers are able to continue to do the work that they're able to do without that additional threat of having our work somehow impinge on their freedom and their ability to take care of people. So with some consultation from the Electronic Frontier Foundation, we have set up Signal. We use Signal for texting all of our providers. We store the data itself in Switzerland on a Swiss server, the Proton Mail server. because the Swiss are hostile to subpoena from anyone in the US. And we ask all of our providers to look at their transcripts within Proton Mail. So they, if they work for UNC, their email is subject to a Freedom of Information request, and same with many other providers. So we wanted to see if we could make that workflow work. And I will tell you that it is awkward. It is really tough to get providers onto yet another platform. And it is really hard to make sure that we get all of our students having to take, fingerprint and facial recognition ID off of their devices. And so it adds friction sort of every day. There's several team members in the room, and so maybe they can speak about this afterwards, but it takes a lot for them to participate in the team and to get up to speed on how to do those things. And what Duke has classified it as is the highest level of toxic data, which they hadn't really experienced before. And so we've been really lucky to work with them, but I also am aware that it took a university like ours to be able to do that kind of team work. And we're really grateful. We have a team member who's on the law school faculty and somebody from computer science and our IT team. So we've been really lucky to do that kind of work. With that, I'm really excited to share with you one of the people who's been key to our undergraduate team, Manasvi Reddy, and she's going to talk a little bit about, we're not going to do what patient perspectives are, but I would point you towards We Testify and Shout Your Abortion, which are really excellent sites for people that want to look for what this seems like from the patient perspectives. Renee Bracey-Sherman and We Testify are doing really excellent work on documenting that. In the Q&A, we can talk a little bit about why we on our team are not recording the experiences of patients. Do you want to share a little bit about what this has been like from the student perspective?
Definitely, thank you. And I'm really grateful to be here today on behalf of the team. I think that this work is particularly exciting to me because of the interdisciplinary nature of our team. Yeah, here's some pictures of us from last year. We have undergraduate and graduate students studying everything from public policy to biology to engineering. And so, yes, we have a lot of unique skill sets, but I think we also have a lot of unique perspectives and motivations for this work. And so working on this team this way, it becomes really evident the critical role that misinformation can play in this space. And by that, I mean that we have legislators with no medical backgrounds passing laws in healthcare. We have physicians who feel uncomfortable and unprotected by the laws, trying to practice freely, but unsure of how to do this. And then we have a general population who doesn't understand the nuances of abortion care, the restrictions that are changing, or how, the implications of these restrictions long term. And so I think that working on this team, it's a really immersive experience in the ways that policy, history, and law kind of intersect in ways that hinder a provider's ability to practice truly patient-centered care, and understanding how these gaps create this vicious cycle of ignorance that can kind of impact the greater social determinants of health. And so the audio archive that Dr. Gray kind of introduced produced a lot of clips that we put on our website, and the students from last year kind of worked together to divide them into these 5 categories. I picked a few of my favorites to share with you all today. And we can go to the first one. It's from Dr. Caitlin Bernard. She's a provider from Indiana, whose name might sound familiar. She received a lot of attention in the media for treating a 10-year-old rape victim from out of state. She was targeted by the state's attorney general, and her medical license was put on the line. But I think this clip is really important because it kind of shows the constant battle that providers in this space are facing, and I think it's really powerful. So let's take a listen.
So, for example, the way that medical licensing board process started last time for me was that people from out of state, not in Indiana, sent those letters of complaint to the Attorney General's office, and they said all kinds of bizarre, nonsensical things. But it's essentially allows him to politically prosecute us. Mm-hmm. And so at the current moment, we have lots of those complaints working their way through the legal system for all kinds of different, a box wasn't checked that should have been checked, or a box was checked that shouldn't have been checked, or somebody at Indiana decided that this abortion wasn't legal. that's what keeps me up at night, is that process, that if I say yes, you deserve to have an abortion, I could end up in another medical licensing hearing, and if they decide that it was an illegal, unlawful abortion, I can go to jail and lose my license. If I say no, we can't do your procedure, then they look at a procedure. We can do everything that we can to get them out of state, but in the end, it may or may not happen. And so any complications and trauma and lifetimes out of state because they didn't get the abortion that they needed, like on me. And so it's like a catch-22.
So Dr. Bernard is like one of the bravest people I've ever met. I mean, she's incredible. And her interview is incredibly emotional. It's emotional for me every time I listen to this, honestly. And why does she have this emotion? Why does she care so much? And it's because of patients like Yenny Glick in Central Texas, who was in a small town, who had a lot of medical complications in her life, became pregnant, and died from complications of her pregnancy before she was at viability. And there were multiple instances, had there been a reproductive healthcare provider in her community, or had she had access to abortion care, she might still be alive today. And these people who loved her and cared for her would still have their wife, their daughter, their cousin, their friend. And so that's why we care so much, because when you're in obstetrics, you see the whole picture. And in the United States, there's a maternal mortality crisis. And if you're a woman of color, your risk of discrimination and death and dying are higher. And so I know we talk a lot about exceptional cases in the media, and these cases like Kate Cox and the Zarowski case, but every single individual who is seeking abortion care has an exceptional life, and they deserve to live it how they want to. And if having abortion access is part of that, I think it's a basic human right. And
Our next clip is from Dr. Misha Pangasa. She's currently practicing in Arizona, and I think that Dr. Pangasa is a really unique asset to our audio archive because she's trained in a lot of different places, Oregon, Utah, etc. And these places all have very different levels of abortion restrictivity. And so I think that hearing all these things, it's something that not a lot of providers can bring to the table. And so in this clip, she does a really great job of explaining why this work is so critical.
And the other part of this that I want to touch on too is particularly for anyone who's in medicine, who has anything to do with people who are pregnant and manages deliveries. We know that pregnancy can be this incredible, beautiful, amazing thing, but it's not for a lot of people. It can be also some of the most devastating moments in people's emotional health, their mental health, their families, their bodies. People end up in ICUs. People end up, even if they don't end up in ICUs, end up with stitches and can't sit straight for a few weeks. Pregnancy and childbirth are not neutral. And to be able to talk to somebody and say, you get to decide how and you want this to go, feels like just such an important thing. And that's why I think so many of us give so much of ourselves for it, because we know that the alternative, it's not just having a baby is some easy thing for you to do. It is beautiful sometimes and really terrible sometimes. The number of people who I've seen, we always talk about pregnancy-related mortality, but I feel like not as many people talk about real pregnancy-related morbidity. And the number of people who have had dialysis, or like I said, just in the hospital with antibiotics, and have C-section incisions that have to carry around wound vacs for weeks for them to heal. These things that are all considered normal pregnancy stuff. Well, I guess dialysis and ICU are. Well, people have surgical site infections all the time. You have to carry around wound vacs and not the normal stuff. And that's a big deal for someone who didn't want to have a baby. And the other part of this.
we talked a little bit about this already, about the stories that are highlighted in the media and how there are so many other stories that aren't told. I think We Testify shares many of those other stories and understands why someone might seek abortion care who doesn't meet exceptions. And I think as we've seen people desperately traveling through the South to get care, we see people living in poverty, people, saving all their money to get here and then not having gas to get home and just trying to feed their families. And I think those cases are exceptional too. And we have a responsibility to elevate those stories and as well.
I'll also add, going off of Dr. Pankos's clip, that I'm from a rural town in northern Texas, and it's a really religious and conservative area. And I think these beliefs are really strongly reflected in attitudes towards sexual education and reproductive health care. But being involved with this project, I think the biggest thing that I've come to understand is that abortion care is so much bigger than just abortion care. It also stems into miscarriage management, socioeconomic outcomes, and like Dr. Pangos mentioned, maternal morbidity and mortality. It's just important to note. But our last clip is from Dr. Gray herself, and she kind of introduces this concept of an abortion desert, which is highlighting another reason that these restrictions can be so harmful, particularly for medical education.
If we have a strict ban and residents aren't able to provide second trimester care or only able to provide second trimester care in emergency situations or the mother's life is at risk, that curtails their experience and whether or not they'll be able to be competently trained in that skill set. And so in another 12, 15, 20 years, you're not going to have very many providers left that have that skill set. And so there are times where I would say even at least once or twice a month, we're faced with a case that's an emergency case, patient needs to be cared for, and the second trimester D&E or dilation and evacuation it's a complicated procedure and you have to have training to be able to do that. And so I worry that in another 10 to 20 years, the patients in North Carolina won't have competent people to be able to care for them in emergencies. And those emergencies will stop happening.
And that kind of leads perfectly into the next part of our project. Aside from the audio archive, some of our team members also do some research on what a post-Roe America might look like. And so what that looked like for us last year was researching how what we called future physicians, meaning OBGYN residents, family medicine residents, and medical students, how they would be affected by the Dobbs decision and changing restrictions. And what we found is that nearly 40% of these future physicians were currently training in a state where they were unable to receive comprehensive abortion training. And so that means they'd either have to go out of state to find this training or just would fail to receive it entirely. And so then if you ask yourself like why that matters or like why would we care, this just kind of is another step towards exemplifying this abortion desert that Dr. Gray introduced. Providers aren't going to know how to provide life-saving medical care, even in emergency medicine or in places that require similar skill sets, which is just going to further exacerbate the abortion desert and make care increasingly inaccessible. I'd also say as a pre-med student from Texas, I think it's something to think about because I'm not sure what my training in this field might look like, in the next 10 years.
So a lot of these stories, so patients sharing their stories, physicians sharing the landscape of what they're seeing can be translated into advocacy to help educate legislators so they understand the implications of the law they're putting in place. And so even before Dobbs, we started a group in 2021 of physicians, nurses, researchers, people throughout the health system who are interested in reproductive health and health advocacy called the Dream Team. And we've been going pretty strong since then. We've had a lot more interest since Dobbs. And it's sort of an outlet where we can discuss current events in North Carolina. We meet with legislators, we go to the legislature, and we're just becoming more educated about the law in North Carolina, the law in the US. And it's just a place where we can come together and learn more about communication. several members of our team have been doing some media briefings, and actually on the day of Dobbs, one of our media briefings got picked up by Samantha Bee. So I woke up on the morning of Dobbs, someone had texted me and they were like, I'm pretty sure you were on Samantha Bee last night. But they had picked a couple of clips, and one of them was from Rick, who was the head of quality and safety at Duke, just talking about why this care is so necessary. And this other picture is from us meeting with David Price. But our students and our residents have been very involved in advocacy, and I think sharing our experience is important, and not being afraid to share our experience is really important, because I think every time Wesley gets her talk about how dangerous it is to be an abortion provider, I sort of put on the earmuffs. But I think unless we're brave enough to share what's happening, people won't talk about it, and then there's this vacuum that gets filled with fake news and misinformation. So we met with many legislators, and I take notes every meeting, and I pulled out a couple of things that I thought were really important. So sharing patient stories can change hearts and minds, and so people are heart-wired. They do. When you share a story, like Kate Cox has been so brave to share her story, people can relate to that and see themselves in her and really understand why she needs care. David Price told us that the work we do is important, life-saving, and we have a moral imperative to continue this work and a duty to participate in advocacy. And that we are taking the moral high ground by doing this work, and not to cede that.
Who was David Price?
He was a former House representative from North Carolina for a long time, from Chapel Hill. So this is a marathon, not a sprint, and it's important to maintain optimism and positivity. And we joke amongst our smaller team that someone always has to be on point as optimists, that we can't always be pessimists. So that's very important. And letters to the editor to local papers make a difference. Like, you feel like, oh, I'm going to get this letter to the editor in the New York Times. Nobody in North Carolina cares about that. They want a letter to the editor in the local paper. That's what your legislators are reading. And so if there's something that you want to advocate for, it's important. And I think, this is the last slide. This is just a quote from Howard Zinn. This is one of our students who's a first-year resident at Northwestern this year. In the middle, Nikki Diaz, in the picture, but the quote says, history is instructive. What it suggests to people is that even if they do little things, if they walk on a picket line, if they join a vigil, if they write a letter to their local newspaper, anything they do, however small, becomes part of a much larger sort of flow of energy. And when enough people do enough things, however small they are, then change takes place. All that we had for the group.
Thank you for sharing.
I have am I on? So one comment, because I didn't get into the issue, particularly of EMTALA. We've talked about the abortion wastelands. In those and in poor communities, emergency rooms become first-line care, and there's no access to OBGYNs in those communities. That's where they get their care. That's where they get their treatment. If you take out the federal guidance of what emergency room doctors just start with before they make their referrals, then you're eliminating a massive treatment center, which is what's being attempted to do. Then and that's why EMTALA is important. And I guess I was asked to talk about what's going to happen, the dangers. I mean, those cases have to be brought by the federal government. If Kamala Harris wins, they'll continue to bring them. If somebody else wins, that'll be it. And they'll change the guidance, and the emergency rooms will be told to follow the state. So there's a second national issue because these cases are percolating. The only other thing that reading these comments that I think should read from a doctor's perspective was Amelia Hunsberger, who said, I'm sitting here in the operating room dry heaving. I'm not dry heaving because of this surgery. I know how to perform this surgery. I trained to perform the surgery. I'm dry heaving because I don't know if this is the case that's going to make me a felon. So I thought I'd add those 2 points in there, and I'll go back.
I think that's really powerful, and I will say as a provider who is not in the family planning clinic, but takes call for GYN and takes calls from physicians across the state when I'm on call, it is truly happening that physicians are terrified to take care of pregnant women with emergencies in their centers. And I think the number of patients we're being asked to take who are not stable to move 2 to 3 hours to clearly not stable because their providers, there's either no OBGYN provider or their provider is afraid that what they're doing will land them in prison or make them lose their license. And that is just exponentially increased in the last 2 years. And so that is there's abortion is healthcare, and this, women should have the right to have abortion, but it is also impacting women who are having GYN emergencies outside of abortion, profoundly. And of course,
And I think while hospitals will pay for your medical malpractice, many hospitals won't pay for your criminal defense. So that is, luckily, we feel a lot of support from our own institution. A lot of lawyers. They're nice people.
I think we have time for a couple of questions. I don't know if there are questions or on chat.
Just because I think anyone who's in here who's done advocacy work before can feel the marathon is exhausting. Have you, in the work that you've been documenting, I'm sorry, this is really found, do you have any stories of moments where you have felt like you really changed a heart mind, where there was movement in a way that was heartening? And I don't know, I would love to hear it. I would love to be heartened.
So I think there are definitely individual cases where I feel like, and I think in North Carolina, sometimes you're not going to necessarily get someone who has been against abortion to come out vocally supporting abortion rights, but you might help them get a little more quiet about their, using their voice against abortion rights. And I think there are some subtle changes like that. I mean, I think, because most people know someone who's had an abortion, if you talk to them, they'll share that, I had this family member with cancer during pregnancy. And so I do think there are times that I haven't given up for that from that perspective. I think there are a lot of really brave legislators in the North Carolina legislature who are not giving up. And I think they're keeping this issue elevated so that people feel safe sharing their stories. People feel, I don't know, there's just more being talked about abortion now than there was 2 or 3 years ago. And I think that's a positive thing because it becomes more normalized. There's less stigma.
I would say also the most recent Kamala Harris speech where she put everyone on the defensive who was for these laws and said that it's really important to support families. And she brought forward some of the stories of young people who've lost their lives while pregnant who were young parents. This was a really different, I'm 55, I've never seen that in my lifetime where people who were supporting abortion rights went on the offensive and looked moderate. So I think this, I have a very old, very Catholic father, and he has been hearing about this journey and he couldn't even hear the word abortion. He was like, don't say that word, don't say that word. And a lot of the students on the team come from families where they are not encouraged to use any proper anatomy terms growing up. So the studied ignorance, the perpetuation of ignorance has been intense over the last 50 years, even as Roe existed. So first of all, I want to thank you for the advocacy that you were doing. And say solidarity is really important, but there's also just a huge amount of people that are, oh, really? Can you tell me more? Why are you doing this work? And there's some students on our project that have just been doing incredible work with their peers on Duke's campus, just letting them know what's happening. And there's just such widespread ignorance on Duke's campus among undergraduates. Just to give one example, we had those 16 pre-med seniors in spring of 23. None of them knew that the OBGYN clinic was 700 yards from Perkins. And they were outraged. So they really put a fire under our butt to like go back to student residential life and say, our students need to know resources, our students need information. There's a lot of sort of small ripple changes as well as something big like Harris speed.
So I had a question about political speech. So right now there's a petition going around among Duke faculty. It's called the Institutional Neutrality and Free Speech petition. It kind of came out from the Gaza Strip or Gaza war. And the first statement and point says, when a contested social issue arises that does not directly concern the academic mission of our university, Duke's leadership will not issue a position statement on that issue. And I'm wondering how you see abortion plays into that, because it's obviously a social issue. I'm wondering if you think that Duke leadership should take on social issues like this and make statements, especially since they're so important. Or is this something that should just, similar to this statement, just stay out of Duke leadership's positioning on anything related to these kind of social issues?
So I helped write Duke Health's position statement. And abortion's healthcare. It's healthcare. And so if there are laws that are impinging upon people's healthcare, it's not political. And so when someone comes to me seeking care, we don't talk about politics. We talk about what they need in that moment. And so I think the same for gender affirming care. Like if there are these attacks politically on this healthcare that has a ton of evidence to support why we should be providing care without bans, and that healthcare is better when we are able to practice in an evidence-based environment. So I think in my mind, I don't talk about, when I talk being in advocacy at an institution, you don't talk about candidates. You're not trying to support one candidate over the other. You're just talking about kind of how the laws impact your patients' lives. And that if your patients want to learn more, you give them information about where to vote. And that's really, so we keep any like political activity very separate from our institutional. That's not to say that there aren't faculty that go to rallies and speak for candidates, but that's separate from their university affiliation. But it is very powerful. So when we made our statement, there were many academic institutions of similar kind of standing as Duke, so like Penn, Northwestern, I think Harvard had a statement. There were many out there that were willing to make statements, but there were many that were not. And I think it is a powerful way to speak out and say, this is the truth. This is medicine.
Well, I think social issues, though, come into not accepting evidence all the time, right? And that's why it's a social issue.
Well, we're scientists, so thanks. I believe the truth. I don't know.
Yeah, I totally agree that it is a healthcare issue. It's not a social issue. And so I think coming out as a healthcare institution positions truth, right? I mean, we would never come out and say the COVID vaccine doesn't work. We're not going to discuss it because there's so much misinformation about it. And yet, abortion access saves lives, decreases maternal mortality. And there's so much
willingness to label it a social issue, not a healthcare issue. So I think Duke coming to the side of science is really important. All right, with that, thank you, everyone.